like seconds.
You had my number.
Really? No.
I follow directions.
Because we're not going to eat it, and it's just going to go to the starving dental students who are in the middle of their midterms in the simulation lab upstairs. So take advantage.
Also, we have our fundraiser this Friday, so I hope you guys are all excited about that. And you should encourage your friends to come out, have fun. It's going to be a good time. All the proceeds are going to Operation Smile, so for kids with cleft lip and cleft palate. So yeah, encourage your friends. Press attending on Facebook if you haven't already, and then you can also invite your friends because it's an open event.
Yeah.
Okay.
Bring your USC IDs and all of your friends. If they don't,
Well,
bring
school
them.
IDs.
If they don't go to USC.
That's fine.
That's fine.
It's
You
fine.
just need to be able to vouch for them,
Yeah.
pretty much.
Yeah, so just know, like, brand.
It's just a DPS because we can tell them that we've been checking USC IDs.
Yeah. And yeah, so it actually, everything worked out perfectly that, we had to move the event back by a week because last week there were the rains and the thunderstorms, but also the dental students all had midterms this week, so they all wouldn't have been able to attend. But now, not only are all the dental students going to be there, but DSD fraternity is actually hosting like this chapter reunion where they have like 6 different chapters from across the nation coming in. So there's going to be like 100 people from across the nation just from the DSD fraternity. So it's going to be huge. Bring your friends, bring your family. I'm going to bring my brother. My nephew's going to be there, 6-month-old party. No, of course not. But you get what I mean. Just bring your friends. It'll be a good time. So next Wednesday is Ostro's Research Day. I highly suggest that you guys attend. This is a good way to get, kind of dip your feet in the water in terms of the kind of research that is done here at the dental school. So you can actually click on the event itself over here, and it will take you to kind of description about the event. And if you go to our website on the updated news, there's a link that will take you to the Research Day's homepage, and you actually have to register for the event itself. So register for it. It's Wednesday. It starts at 11:30, but you don't have to be there until, I believe, 12:30. That's when open registration begins, when you can walk in and get lunch and hear all the keynote speakers. So I know Dean Sadan is speaking. Dr. Chai is also speaking, who's the Dean of Research at Ostro. So it's going to be incredible. It's definitely a good way to get, some kind of experience with the kind of research that is done here. And you will also get to talk to some of the research professors because they will be presenting the research that they're doing. So, yeah.
Amber and I are actually presenting on Wednesday. So if you guys want to come and find us and talk to us, we can introduce you to anybody in our lab that you want to talk to. I'm sure they'll be presenting. But yeah, come find us so you won't be alone. Come see our awesome poster.
It's great. You guys should all come. It's really good.
DDS Family Network. So, after that, it's spring break for a week. You guys won't see us, and I know how much you'll miss us. Try not to cry.
You want to go to Vegas?
Yeah. No. But after that, we have one more meeting after that, right when you guys come back that Wednesday. And then that weekend is potentially our last social, and that's Really for Life. So we'll give you guys more information about that as the time comes. But most of you are familiar with it. It's been at USC for years and years. Lastly, do you have anything that you want to say? Yeah.
People's emails, there are a lot of over quotas, so you have to clear your inbox, and that's why you haven't been getting your emails. So some names are Nick,
That was got one.
Like if she's listing them out, it's like call them out.
There's only a few. Madison
Calling me out.
and Esteban, that's it.
Okay.
Oh, are you done? I was going to talk about the CHIP. So one of our last service events is the CHIP Health Fair, which is on the calendar. It's on April 5th. It's at the Hoover and Adams Recreation Center, which is like the park on Hoover and Adams. And basically, they get all the pre-health clubs from USC as well as all the health, actual dental students and optometry students and med students and stuff to come out and provide educational workshops and free screenings, and there's performers that come out and dance and stuff. So it's from 9 to 3 and there'll be 2-hour shifts. And so if you come to that, you can count that as either a social or a service point.
Yeah.
And yeah.
Cool. And we'll keep you guys reminded about all the events, so don't worry about that. That weekend also, the 4th to the 5th, we're gonna start planning right now a trip out to San Francisco to visit EOP for their school Pride Day. So we will actually get to visit the brand new dental school at EOP, which is amazing. And then also on the 4th, the plan is to visit UCSF. So by show of hands, I did this for UCLA Shadow Day, and literally all of you guys raised your hands, but maybe a handful of you actually came out to a Shadow Day. Who would actually be willing to sacrifice their Friday and Saturday to go visit these two dental schools? Like, drive there, stay overnight, and then visit the two dental schools. Raise your hand. It's that weekend, yes.
European UCSF.
4 or 5. Is that April?
Yes, that's April. So raise your hands. Okay, no? Well, weekend? Okay, so we'll send out like a sign-up sheet or something and see how many people can do it. I think that's it. So we have literally 2 more meetings. So it's the 5th general meeting, and then the 6th general meeting is elections, and that's pretty much our last meeting. We have 1 more month left of DES. And then our end of the year banquet is a month from tomorrow. So it's wrapping up quick. Get your points together. Make sure you get Cardinal Gold membership. We all want you to. Yeah. I think that's it. Do you guys have any last announcements? Okay. Before I introduce our speaker, we want to announce the members of the month. So, I don't know if she's here right now, but oh well, it's her birthday on Friday, so this will be an early birthday present for her. Sydney Goldman. Is she here? No? Okay. And then, so our second member of the month, he's actually a DDS success story because we converted him from Coon Ed. So, success, yes. He's a great friend to all of us on DDS. He's an excellent member. Goes to SSC, attends all the social events. Join you back. We have to get you research certificates, so yeah. Okay. So I'd like to introduce our speaker for today. He was a former president of DDS, so you guys should all feel really honored, as I do. He is an expert in his field, prosthetic dentistry. He teaches not only here, but taught at UCLA as well. Not only that, he maintains his personal life and maintains a business and clinic. He does all these things all at once. So it is very admirable and just, it's great to see, that you can have a life and be an amazing dentist as well. So please welcome Dr. Oche.
Hi. Let me tell you, I'm just very, very thrilled and proud to spend some time with you folks today. Mike's right. I went to undergrad here at SC, and I did my dental training here at SC, and then I did my maxillofacial training at UCLA with your dad. And I did my prosthetic specialty training here at SC, and really, in my career, I've had nothing but good luck and fortune in being trained by the highest level of professors in their specialties at the time when they were the program director. Okay, my maxillofacial prosthetic program director, John Bumer at UCLA, he wrote the textbook. He was all in charge of all the specialty organization, and Jack Preston. And I can tell you that the more you educate yourself, the more you put your effort into what you want to become, you really get more than what you put into it. It just snowballs. So what I'm gonna do today is, I'm just gonna talk to you about kind of my specialty, maxillofacial pros and prosthodontics. But really what I wanna do is kind of share with you what it takes to, I think, be successful in dentistry. Because I think the economics, the science, and the educational system has changed over from like 25 years ago from when I first started practicing. I mean, I was in the same room, in the same seats, and I took biology in 106 with a guy named Perkins. He still could be around, I doubt it, but in Bovard. And, you know, in that time period, the thing that remains constant is the effort and dedication that you have to put into it. The science, the technology, the techniques, the economics, everything changes, but you never change. And that's something you really want to showcase when you guys do things like interviews, writing applications, writing essays, picking your own classes, picking dental schools where you think you're good, where you're best fit. Of course, I want you guys to come here, but I know that this isn't the best fit for each and every one of you. The main thing is, first thing, is you guys all gotta get in someplace, anywhere. I don't care when. I do, but just get in. And you gotta want it really, really bad. Don't blink, just dedicate everything you do, and it will happen, okay? So, we'll just keep talking. I've taught restorative dentistry pretty much my entire career here. I did a lot of, you folks know the JP program? I got to tell you, I participated in JP when I was undergrad here, and I will tell you that it's, as practitioners, what is your job? To teach patients, teach people. How do you learn how to teach patients and people? You learn to work with kids, and at the same time, what do? You're putting an effort. You're putting your time, your effort, because you got a lot of time to watch TV and go to football games and stuff. But you got enough time to go drive to somebody's elementary school and work with kids, teach them how to read, write, draw, do anything. Okay? And the same token, you get another checklist on your volunteer efforts. And it's one of the programs at USC that a lot of other colleges do not have around or in Southern California, and you really should take advantage of it. So, dentistry is really multidisciplinary, okay? And what I'm just gonna share a bunch of different things. I'm gonna pull things all over the place because I've spoken with, you know, all kinds of different groups, and this is kind of a unique group. In dentistry, whenever you do a procedure, there's a standard of care, right? Okay. The standard of care for each procedure is dictated by each specialty, okay? Right? So if you go to the corner office and it says orthodontics, if the orthodontics done in that office aren't to the caliber of what an orthodontic specialist that was trained, that did their dental training and then 3 or 4 years post-op, what they say the way to do it, then you're not treating to the standard of care. People do orthodontics, okay, minor tooth movement, but how do you know when the small treatment is good enough or inappropriate? Okay. Putting a bandage on a laceration that requires 10 stitches is an adequate treatment, right? In dentistry, we have a lot of offices all up and down Hoover and Adams, right? Then we have this beautiful facility here, but people go to all these different places. And what separates our facility here from those other places is that the legal standard of care. And the legal standard of care in the state of California is that determined by all the different specialties. So when you train in dentistry, a good school will have all the specialties covered in that school. Okay? And you will get trained by specialists in each one of those different disciplines. That's why a lot of restorative dentists that teach on the dental school clinic floor are prosthodontists because they're restorative specialists. Okay? So these are the different specialties in dentistry. And they all kind of, if you notice here, we have a couple things that, the two things that are missing that are not really recognized specialties are in dental implants. Dental implants is not as specialized. You can say you're specialized in dental implants, but you're not. You can even say you're a dental specialist, but there is no specialty of implant dentistry. There are organizations that kind of look good to the consumer, but that's all they are. They're titles so that people come into an office and have confidence to buy treatment from different offices. But if you're a difficult case, you actually might need to go actually see an oral surgeon, a prosthodontist, or a periodontist to have implants put in. I'm sharing these things to you because I don't think a lot of the lecturers or speakers have a broad overview or background. And I just kind of am comfortable talking about it. And if I say anything that doesn't make sense, ask questions. Okay? Because you guys are supposed to be sponges, right? When we're talking about teeth, there are micro pictures and macro pictures. You know, microeconomics, macroeconomics, that kind of thing. In dentistry, operative dentistry is where we concentrate working on, like putting one crown on. You know, fixing one tooth though. Okay? Prosthodontics is where we coordinate so all the fillings that go in place are like the four tires on an Indy car. They're matched. So everything works perfectly. You go around the curve for most efficiency. Or in prosthodontic terminology, they're coordinated so the bite, when it opens and closes, doesn't cause damage or discomfort to the jaw joint. Okay? In one of the things that you want to learn or you want to know about is, in dentistry we talk about the occlusion of the teeth, okay? And when you're first learning dentistry, there's a class called occlusion. And it seems like it's really difficult to understand, and it's not. What it is it's the class that you get your first year that has you memorize all the grooves and cusp position of all the teeth. Because how teeth touch determine how the jaw moves, which relates to the muscles. Okay? Is this too much science? Is this too serious? Well, we're just talking. So, my feeling is anything I could share with you that helps you understand when you see dentistry done on the clinic floor is good, because it makes you guys look better when you ask intelligent questions or have intelligent ideas. Because when you're learning, the whole idea is perspective. I have found that the hardest thing when you're learning your first year is perspective. You get a book, say you want to take that class in genetics, but there's so many aspects of genetics it becomes overwhelming, right? When I studied genetics, the RNA, the polymerase test was literally a 12-volt battery with wires on a glass plate. Okay, now it's a $1,500 test that you send out to a lab and they run an assay on it, and it's about 30 seconds. Okay. You want to get a perspective of dentistry by visiting as many different people and places as you can so you know how you're gonna fit in and where you're gonna be comfortable. Okay? Sometimes it's easy to just aim for the top, but sometimes you miss the big picture if you aim for the top too soon, okay? So, in prosthodontics, our goal is to restore missing teeth, and we can do it any number of ways. Can we turn the upper light off? Okay. Better, you can see something. So, the lower arch here, those are actually, this was a bridge, and the lateral's missing. And from my perspective, I think this is an implant and this is an implant. This is the occlusal view, and you can see the dots here where I use a screw to take the tooth on and off. And I'm not shy about leaving this exposed so you can see it. This was an adolescent patient. She was still in high school. So as people grow, their jaws develop, things move, they might need to be replaced. My philosophy is if things are retrievable, they can be changed. It's better than having to cut off something, which I think is really primitive. So I did this when she was high school, and she, I don't know, 10 something years later, she's now a graduated physician from Stanford Medical School. But my point is that there's different ways to do the missing teeth. One is implant, one is bridges, and we can also do ceramic coverings. And, you know, this is obvious. There's an obvious need for restoring this dentition, but it has to be done logically. Because how do you do it? If you just open up the bite, you know, what's going to prevent it from breaking again? And where am I going to open up the bite from? This is a case where he was like a 42-year-old boxer that loved lemons, and so he bruxed or ground his teeth in the presence of an acidic food, okay? So we have a combination of erosion from the chemical and attrition, which is the light tooth surfaces, okay? So we diagnosed him, and I determined that I needed to open up his bite, about 3 millimeters in the back, and I couldn't tell if he was going to be comfortable. So I made him a plate, temporary plate, that he could wear for several weeks to make sure that his jaw muscles were going to be comfortable. Think about it, if you just went from, you know, being, you know, you had foot extensions, and you had to go play a basketball game or something, and they added 5-inch lifts to your shoe. Can you go run around right away? No, you're gonna fall over yourself. Well, some of these guys with jaw comfort things, they're the same way, so you have to do it incrementally. Everything we do in dentistry, there's no hocus pocus. It's all logical. Everything's logical. If it doesn't make sense, ask questions, okay? So, when we put a restoration on the tooth, patients think, oh, you drilled my teeth down all the way to a little nub to their nothing. But what you learn in dental school is that when we do a tooth preparation, we're only dealing with the exposed clinical portion of the tooth. That's only maybe about 30% of the total tooth. Other 60-something percent is still in the bone. Okay? And we do, there's a prescribed shaping of these tooth preparations. If you make them too tapered, okay, it's going to fall off and need to be redone. If you make it too short, it's going to fall off. If you make it too parallel, you're never going to get it on, right? If you cut too much of the tooth, you're going to create toothaches, right? And if it's too thin, the porcelain crown is going to be too weak, it's going to break. We have parameters that we teach in the first year dental school that teach everyone how to understand and know these things. Okay? Every school across the country does this. Now this is called the dental articulator. Okay, and what this does is it simulates jaw motion, actual jaw motion, okay? And the way it does it is, this is a pantograph, which actually records the movement of the jaw in three dimensions: frontal, sagittal, horizontal. And all it does is record a little line tracing that you map. There's a little, takes a line and a little chalk mark, and then the line setting gets converted to these angles here. Okay? Why is this helpful to see? Well, those line settings translate, this is the old way of doing it, which is waxing these things in hand, by hand. Yeah, I did this. You gotta have some good hand skills in dentistry, okay? In fact, some of the best surgeons were dentists first, okay? And then we, since you had a history of bruxing, I didn't want to put tooth-colored porcelain because the material is very brittle and it will crack. So we mutually agreed that metal surfaces would be good for his back teeth. And then a metal surface chewing on the back of the anterior teeth, and then the rest would be porcelain put on after the fact. So this is kind of a final result. It's not bad. So, you know, gold is the technology of 30 years ago, and white is probably today's technology. We have a material called zirconia that is very strong ceramic material that we use for a lot of the tooth-colored porcelain. Okay. It's similar, it's almost the same material, those, you know, those white Kyocera ceramic knives. Same material, very, very strong. So we know the way teeth move. I'm not going to go through that, but there are comparatively, depending on how you're built, you're going to have different degrees of tooth movement. And if the jaw moves flat or steep, the cusps and the shape of the teeth are different for each patient, each person. So in the 30s, USC was at the forefront of this technology. USC was the school for teaching occlusion. Have any of you been on the 4th floor and seen the articulator cabinets? Yeah. Okay. The articulator cabinets record the history of the occlusion studies that were done here at this school. This is the oldest school in Southern California. This is where everyone came. The other school is at. Okay? It wasn't around. Okay, that's the commuter school. No, everybody came here. And they didn't have things like computers then, but they had analog devices. And this was from the 1930s. This was a pantograph from the 1930s. And we actually used this on, we pulled it out and used it on somebody. We got it to work. It's perfectly good data. And my point is, it's the same information that you would get if you were to do today's equivalent, which is a magnet recording point in a magnetic field recorder, which is called a jaw tracking device. And so this jaw tracking device measures on a computer screen how the jaw moves, so that on a virtual articulator in a computer, that these cusps and fosses are recorded and moving the right way so that you get maximum efficiency and comfort for the new restorations. And what we do today is really no different than what I do in wax. See, today in the past I would do the carving with instruments, and today you guys should be prepared to not only carve with your hands, because it's the only way to deliver the care to the patient, but you also have the computer mouse ability to play with it virtually using digitized imaging. Okay? And this is a Siemens cable machine underwater. USC has all of these machines here. So basically, this is done by Rex Ingram. Rex Ingram just passed away this past year. The clinic is named after him. He's the father of restorative dentistry at USC. He had the most beautiful hand skills. And literally, gold required good hand skills because gold is a soft, malleable metal. And you can actually, if you had a slight error or something, you could actually bend it or swedge it against the tooth tighter so that there was no line. But because we got such a good fit with the gold, this is the standard that porcelain restorations have to come up to. So if we cannot get the porcelain restoration to have the same fit, then it's considered inadequate. Okay. So maxillofacial defects is the correction of defects in the upper head, not only the mouth, but from the shoulders on up. And it could be caused by tumors, cancer, surgery, traumatic injury, birth defects. And the appliances are the appliances used to restore function. And I'm just going to kind of go over this subspecialty that I do because my skills from dentistry allow me to treat things more than just teeth. Okay? So this is an orbital defect. And this patient had a cancer that required enucleation. It looks kind of tough, but you know, she still has vision. And we use dental implant technology to have magnet-retained prosthesis. Same with the nose. Okay? And when you think of things, I don't have the thing, you know, if you had have both of you said studies in cancer? Not really, kind of. Well, squamous cell carcinoma is probably the most aggressive type of cancer you can get. It metastasizes and spreads very easily. You don't want to get it, okay? There are other carcinomas that spread slower, but squamous cell is very aggressive, and once it starts, it can go into the nodes, and it could cause problems. So if we were to, like, say, make a pedicle and cover this, and she had a spread later on, you'd never see it, okay? So one of the advantages of this is the nose is just there to block air so she can get her speech. Same with the eye, because there's communication with the sinus. If you have a big nose, a hole here, it's hard for you to speak because the air comes out. It's like having a big nostril. Maxillofacial pros is a really, I think I really love it because the fact that it interacts with so much more of the patient than just the teeth. I have to teach patients how to chew, how to speak, how to think, you know? Think about it. And it's true, you do have to learn how to think, you know? You could think of what you're missing or think of what you have, right? Some of them, well, I don't have my nose, I need my nose back. No, you have it's kind of like you've got a nose that's now kind of like the hood to the engine of your car so you can go check to see if things are wrong. You have access. Ear appliances are easy to restore. And if you do bone conduct, this is really old, like 20 years old. And also maxillofacial prosthodontists work in the cancer centers with head and neck cancer patients and work very closely with oral surgeons. Oral surgeons like us because we're the ones, after they do huge surgeries, we're the ones that can actually get the denture to fit, the teeth to fit, or the prosthetic device to make the patient whole again. And what radiation does is, radiation attacks the periosteal layer of the bone, so the bone can no longer repair itself, okay? Think about it. If your bone doesn't repair itself and you take out a tooth and there's a hole, what happens to that hole if you have too much radiation? It doesn't close up. Now you put that in your jaw and the hole, instead of closing, gets bigger, 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 pretty soon you end up with a pathologic fracture and you end up with a jaw that's in 2 pieces. It's miserable. So what we do is that we have a protocol for patients treated with radiation, where we take out the teeth before they get the radiation so that the gums heal up first. Then, if they have tooth problems, like this was caused by the radiation, we treat like this sequester. We actually do not treat this. This will, it'll slow, it's kind of a little stinky, but at least they don't, the jaw doesn't become fractured. And they can keep this clean with oral rinses. This is kind of an area of dentistry you guys didn't know about, right? Also, from 2005 on, there's an area of where medications were found to affect how bone heals. And you folks might have parents or grandparents or something that have used bisphosphonates such as Fosamax. You know? Fosamax is a medication that's prescribed for osteopenia, where the calcium depletion occurs and then people get really brittle bones. But what they found was that it stopped the osteoclast. You had biology, right? Stopped the osteoclast from actually functioning. So the homeostasis pattern of the osteoclast, osteoblast, the bone actually stopped healing, and you had a situation similar to radiation, only it was just as bad, only it was systemic. Radiation is just to one area. Medication-induced bone problems are the whole body. Okay, this is a kid that had radiation, and a 14-year-old should have all the teeth erupted by now, but he's got, you see where the radiation is called delayed eruption. And this is a situation where we have a surgical resection, and from the radiation, the area never healed, and he ended up with a pathologic fracture. Radiation planning. Maxillofacial prosthodontists work with radiologists and planning what areas of the mouth or the head and neck can be actually treated. Yes?
So when the bone doesn't heal, that just happens randomly, right? That's not like overexposure to radiation, or is it?
The radiation, you would know how much radiation is in each field. Now, these are really old photos, because now this is all on a computer screen overlay, okay? And if you were to look at this, this is the dentition, and you can see a nasal pharyngeal areas all in the field, but the teeth and jaws aren't. So if you had this as your treatment planning evidence, you would know that you could do treatment of the areas that are not in the field of treatment safely, okay? Based on knowing where the cancer is. Okay? Now on this patient where the base of the tongue cancer is, you pull the films out, and then you know that, oh, his whole lower jaw has been in the field. And then you know, oh, he had 6,600 centigrade doses of radiation. Then you know, I cannot take these teeth out, or I cannot put implants. So you make dental decisions based on the medical document that you pull and talking to the physicians. A long time ago, okay, we had, you know, people used to say, oh, you applied to dental school. You didn't get into medical school? It doesn't work that way. It really doesn't work that way. There's a lot of, I'm much happier doing what I'm doing now than if I did the 4 years of medical school thing. Are you sure? Because the medical school thing is not for everybody. It's very doable and it's very rewarding, and you got to really love the hospital environment. I was in the OR all morning. So, you know, it's fun. It's a separate thing, and I encourage you to volunteer and learn about it. But my point is that as a well-trained dentist, you are on equal level with any of the medical physician specialties. And you can talk even one-to-one on them, and you don't have to think back, because you're serving a specific need that they cannot serve. Okay? So this is just some other views of the same type of areas that are treated. And as dentists, you know, we use the same technology for sports mouth guards. And here we use it to deliver fluoride and protect radiation backscatter of the cheek. And these are just some appliances. We make all sorts of appliances. When patients don't have this type of treatment, the dentition breaks down really dramatically. So this is gradual Panorex with the dentition when the patient doesn't maintain after radiation. And you can see it's just really broken down tremendously. So these are what post-surgical defects look like that I deal with. These are upper jaw. This is the upper jaw, no teeth. This is the view from the mouth, and this is the nasal sinus. This is a similar view. And here we have a couple of implants to hold a denture appliance in place. And these are just more examples, more implants, more defects. This is a normal ridge with no teeth. This is a partial remaining ridge, and this is the defect. And here's the defect, and there's teeth. And all these defects, they're, if you weren't trained or you weren't familiar, yeah, they can be kind of scary, but I'll just tell you that you can be comfortable working with these patients, because after all the surgery, these people are pretty much normal. Okay? The surgery, the cancer, the disease, that's what you're getting rid of. But the people inside, is the same person pre-surgically you talk to is going to be there after you talk to them, as long as you take good care of them. And they're very, very appreciative of what your efforts. So these are some of the appliances that prosthodontists make. This is called an obturator, because it blocks the liquid from coming out the nose. Orange juice through the nose is not cool. So we grab, using clasps, we grab onto as much of the remaining dentition as possible. This is the framework that is processed into this. So we make this framework first, and then we pry it in, and then we make the acrylic resin obturator portion secondarily, a separate visit. We probably make things in about 3 or 4 steps. And the reason I explain it to you, it's not really confusing, it's pretty easy to understand. And this is just an example of an upper and lower denture and an implant. 2 implants is all the difference in the world for a patient that ordinarily in the past couldn't eat hardly anything. This is a patient had 4 implants. And here's a patient where it had a lower jaw resection. And when they have the lower jaw missing, the tongue gets sutured in place, and you really don't have, you lose all your control, because instead of having 2 joints, you have 1, and it becomes a universal joint, and there's no coordination and control. So what we do is I designed the implant bar. This is a normal implant bar with 2 joints. I have to design the implant bar so that it rotates to where the 1 remaining joint is. The surgery was on this side. And this is the patient after surgery. You can see she had a neck dissection, lived through everything, small prosthetic appliance, but she can chew and swallow. She gets along okay, and looks most important thing, socially she looks good for the rest of the family. This is another, it's important, you know, because, you know, think about it. If it's your grandparents, they're afraid of them scaring you if you had such of not being recognized. So this lady, this is a completely reconstructed lower jaw from a fibula-free flap. That means this patient had radiation, and the radiation killed the blood vessels. So the surgeon and plastic surgeons take a chunk of bone with living tissue and the blood vessels are rehooked up to the carotid artery so that the bone segment will live. And then the bone segment grows into where the jaw is because the soft tissues are so damaged by the radiation. We can make devices that have an amazing ability to look pretty darn good just using silicone. We use the pink wax that we use for dentures, we carve them up, and then using a lost wax mold technique, we actually process a silicone appliance that's glued in place or snapped in place. Now, this is an example of somebody that elected for plastic surgery. Okay. I'd rather have the sculpted nose than this thing, but this was okay for her. This is really okay. If she likes it, I like it. You know, you cannot get into the head of every patient, nor should you, but just understanding him and supporting him is your best, is what your job is to do. Sometimes you get really small appliances, and to understand how they're done, you know, we use the same techniques and technology I use to fix teeth. So here's the defect. Main thing is always protect the airway. So I put some gauze in there so it doesn't go into areas that I cannot pull the impression material out. Then I use the alginate that I use to make a mold of the teeth. And then there's no mold, it's soft. So what I do is I put gauze and stone over it to make firm up the mold. So I make it in three layers. I make a stone cap, then I can wax up the defect very slowly. I take a piece of wax, first thing is I position the oculus, which is just the eyeball only. And the most important thing on that is having an artistic sense of knowing that the reflection of the pupil is the most important thing because that shows a gaze and you want to have a neutral central gaze. Then, after that, we put on the medial and lateral canthus, which is where the eyelids open. And you have to, what you do is that you use your artistic sense where we limit the amount of sclera that shows to match the contralateral side. Okay. Prosthodontists, I will tell you, love to go to art museums because it's the same skill. And it's not work, it's play.
Sorry, students have class at 6.
Okay.
Sorry.
We'll be done. And this is, we put a lot of some stippling on there and some shaping. Then we melt out the mold and inject the lightest colored silicone. And the silicone is then painted. So even though this looks really white here, right? Art from all the great masters in all the greatest, the Louvre, any of the Rembrandt, paint is put on in layers. And when it's put on in layers, it gives things depth. And depth adds realism. And once you understand that, we start with 3 colors, and mixing 3 colors, we can get the greens, we can get the browns, and then we put this on in layers. So here's the first layer, about the 3rd layer of paint, and we do it over maybe 2 or 3 days.
What? No
Looks
way.
pretty good, right?
Yeah.
It's not that hard once I've explained how it's done. Okay? Same thing. Okay? A defect is a defect. Okay? But once you learn the skill set and you have the training, you can complete any project. Okay? So, same principles, where to put the implants, where can we not put implants. Here she had a little bit of radiation, and so one of the implants failed, I think right around here. There, one implant failed, that's the red arrow. Same surgical sculpting sense, paint. And the implants retained. She's fine with one eye. Beat Carol. Always compete, concentrate on what you do well, not what you don't do. And you guys will be really successful. Okay? So I can stick around for questions, or you guys can go to class, okay?
Like, how long does something like that take, you know?